Hello, everyone. Thank you for joining us. Today, we are pleased to have Dr. Frey, who will share an evidence-based review on the course and management of bipolar disorder in pregnancy and the postpartum period. Dr. Frey is currently Associate Professor at the Department of Psychiatry and Behavioral Neurosciences at McMaster University, Canada, Academic Head of the Mood Disorders Program, and Director of the Women's Health Concerns Clinic at St. Joseph's Healthcare. Welcome, Dr. Frey. We're really pleased to have you this morning.
Well, thank you, Debbie, and thanks everyone who joined us online today. It's really my pleasure to give these types of webinars for anyone interested in the area of perinatal mood disorders, which is an area of that's much needed in clinical service everywhere, and where the research is really a lot limited. So we have to make sure that when you talk about treatment and knowledge on perinatal mood disorders, that we have a good review on the evidence that is out there, and also make sure that we understand the limitations of the evidence. So first of all, I'm both a researcher and a psychiatrist. So I do research probably half of my time, and then the other half is split between seeing patients and doing some administrative work for the hospital and for the department. So I do see patients, I do follow cases. So if anyone has more of a clinical questions towards the end of our webinar today, I will be more than happy to answer the questions that I can. So let me see if excellent. So the learning objectives of today will be to review and discuss the course of bipolar disorder in pregnancy and the postpartum period, and also to review and discuss the management of bipolar disorder during the perinatal period. So why is this important? The obvious answer is the risk and the suffering of some of our mothers that suffer from bipolar disorder when they face mood, anxiety, and other types of challenges during the perinatal period. But I put this slide up just to also make the point that there is now robust evidence from several studies showing that depression, mental health problems, but the evidence is stronger for depression, that depression in pregnancy can also affect the development of the babies and the infants. So this is a very nice review that was published in one of the top medical journals called The Lancet, on the effects of perinatal mental disorders on the development of a child. So when we think about what we should do for our mothers during pregnancy and the early postpartum period in order to help their symptoms, we are also helping their children moving forward. So I think this is also adds to the importance of this topic. So you can see from from what I've highlighted in yellow here, this is from the article that postnatal depression or postpartum depression has shown consistent associations with a wide range of cognitive outcomes in early childhood, including the ability of infants to learn and to achieve their major developmental milestones, language, and so on. So this is just to highlight the importance. And what is also important from these studies, that I'm not going to talk too much about it in the rest of my talk today, is that the severity of depression also matters. And this is very important because if we can help mothers to feel less depressed, even though they sometimes still feel depressed and they are not 100% fine, that alone can also help the child moving forward. So if we can decrease the degree or the severity of the depression, that already has a positive impact on these children throughout their life. So this is also important for us to know. So There are a couple of citations, there are a couple of previous studies that ask mothers with bipolar disorder, have you ever, what I call crude assessment. Crude assessment is, you just simply ask, did your mood get worse in pregnancy? So you can see from different studies that about half of women with bipolar disorder would tell their healthcare providers that their mood somewhat got worse during pregnancy. But this is still unfortunate because it's already been more than 10 years ago. Still the best study published thus far, so the data is very limited. There hasn't been other studies following mothers longitudinally throughout the pregnancy, but this one did. So this is what you're seeing here is 89 women with bipolar type 1 or bipolar type 2 disorders. At the onset of the pregnancy here, I hope you can see my arrow. Okay, they were all doing well, and they were all on medications. So when they found out that they were pregnant, a group of them opted to continue using medications, and a group of them opted to discontinue the medication. And this study is showing very clearly that in women who continue on using their medications, 37% of them had an episode in pregnancy, whereas 85% of women who stopped their medication when they discovered that they were pregnant had an episode in pregnancy. So this is just to prove the point that for those women who opt to continue using their medication in pregnancy, there is evidence that the medication is helping them decreasing the risk of a relapse. This is another cartoon from the same study when they looked at the difference between those who stopped their medication abruptly, here in yellow, and those who discontinued the medication gradually, which is what we normally do in the clinical practice. And there was a major difference that half women who stopped the medication abruptly had a recurrence in only 2 weeks after that. So the relapse came really, really early. As opposed to those who discontinued more gradually, it took 20 weeks for half of them to have an episode. So a major difference in terms of how to discontinue the medication if one decides to do so. Another important point from this study is that the majority of recurrence during pregnancy were depressive in nature, or what we call mixed. Mixed means, a mix of depression and manic symptoms. The majority of the recurrence occurred really early in pregnancy. The first trimester were more prevalent than the second trimester than the third trimester. And what I just said, the recurrence were earlier in those who discontinued the medications rapidly compared to gradual discontinuation. So this is, as far as I know, still the best study ever published in terms of following women with bipolar disorder through the pregnancy. A colleague of mine from University of Western Ontario here in London, in Canada, Dr. Virender Sharma, he's a great advocate for perinatal mental health. His group published this systematic review of studies in pregnancy and bipolar disorder a number of years back now. And back then, there were only 2 prospective studies in pregnancy. Both were conducted in tertiary care centers. There was a small study that I didn't add the slide here, women specifically using lamotrigine, but the study was very small. And both studies found high rates of relapse in pregnancy. However, according to this review, when they looked at data from non-clinical samples, so women followed in the community, mostly from obstetric or community-based service, in fact, they found low prevalence rates of mania, hypomania, or bipolar disorder. They found lower rates of use of psychotropic drugs, so lower rates of use of medications in pregnancy, and lower rates of psychiatric admission in pregnancy. So even there was in the discussion the question whether pregnancy was, quote unquote, this is my quote, protective to some women with bipolar disorder. And I think this is also important to know, because when we look at the evidence, scientific research, these studies usually present the mean of a group of people that were followed, but there's definitely, and I've had many patients myself here in the clinic that said that the best time of their lives were when they were pregnant in terms of mood stability. And a number of them were not using any medications during pregnancy. So in other words, for a percentage of women with bipolar disorder, in fact, the pregnancy helps with their mood. So there's definitely a subgroup, a particular group of women with bipolar disorder who find that these elevated levels of hormones that are exposed to estrogen, progesterone during pregnancy actually help their mood. And there's also another group of women that actually feel worse. So we have to keep our mind open that what studies show not always, is applicable to a particular person in front of you in the clinic. So if we gather together, the studies that looked at rates of mood episodes in the postpartum period. So now moving away from pregnancy now into the postpartum period. The story is a little bit different. It is really, really consistent that women with bipolar disorder have high rates of relapse in the early postpartum. And there are a couple of studies that you're going to see here that compared women that were on treatment or not on treatment, and being on treatment actually decrease the risk. So a couple of years ago now, Dr. Verly Bergink from Rotterdam, from the Netherlands, she's also another perinatal mental health advocate, someone who's a stellar researcher in this area. So her group published this very beautiful meta-analysis. So meta-analysis means that they gathered together all of the studies that looked at relapse into a mood episode in the postpartum, and they meta-analyzed it. So they grouped the results, and we now know that we can tell our patients that the risk of relapse in the postpartum period for women with bipolar disorder is 37%. So about a third of women will have an episode in the postpartum period. And look at the sample size is really big, like 4,000 deliveries over 3,000 patients. They did not find any difference between women with bipolar type 1 disorder versus bipolar type 2 disorder. And they did find, as I already alluded to, that women on treatment had less risk of relapse, so 23%, 1 in 4, versus 2/3 of women that were on no treatment in the postpartum period. So again, this is another evidence that for those women who opt to or choose to stay on their medications during the postpartum period, there is robust evidence saying that the risk is indeed the decrease for a mood episode. Now, let's talk about timing of this postpartum mood episodes. When do they typically start? So the studies will tell us that symptoms of mania or hypomania or psychosis, when they happen in those postpartum, they can happen at any time, okay? But most typically, they start in the first week. And most patients, more than half of them, will report that they had already symptoms starting on day 3. So psychotic symptoms, which means delusions, hallucinations, like believing things that don't exist, or hearing voices, or seeing things that don't exist, or having manic symptoms. When they start, they tend to start very early, like very soon after the baby is born. Postpartum depression is another story, though. Although, like I said, it can happen at any time. Most women report that the postpartum depression occurs between the first month and the 3rd month of pregnancy, so between 4 and 12 weeks postpartum. So typically, the manic symptoms, when they occur earlier, and the depression, when they occur, they tend to occur in the first 3 months. But again, on an individual case, these symptoms can happen at any time. All right, so we talked about the evidence of the course of bipolar disorder in pregnancy and the postpartum and the risks. So how can we manage that? What can we do to improve outcomes? So I will talk today about things that we have to consider in terms of deciding the management of the treatment of bipolar disorder in pregnancy and postpartum, because every case is different, and we need to obviously plan the treatment to that individual in front of us. So there are many things that are different from person to person, from patient to patient, that we need to take into consideration. I will also talk a little bit about medications, because this is one of the areas that as part of my clinical work, and I tend to receive a lot of questions about risk of medication. So I will address that in the next few slides. But when we talk to our patients about things that we need to consider in terms of managing bipolar disorder in pregnancy and postpartum, one of the things that is very important is that what's the risk of that illness reoccurring? So we have to ask our patients, what was the frequency and the severity of her past episodes? So for how long has she been feeling well? When the symptoms happen, how long do they tend to last? What's the history of a treatment response in the past? So in the past, for that person, whenever she started medication, she responded really fast, so that's good. Or it took a long time for her to find the treatment to respond, and she felt depressed or manic for a long time. So those are the things that we need to consider. We also need to consider suicidal or self-harm thoughts or behavior. So risk assessment of self-harm is something that is really important, because it could become an emergency for us in mental health service. So we need to ask patients openly the questions. Most women with suicidal thoughts, they don't attempt suicide. Most women with thoughts, they don't have any plan and no intent, which is very important, but we need to make sure that we ask those questions. But if they do have a plan, if they do have an intent, we have to take emergency steps to obviously ensure the safety of that person in front of us. We also need to ask about current or past psychotic symptoms. Psychosis means, like I said, believing in things that don't exist, called delusions, or hearing or seeing things that don't exist, like we call that, those are hallucinations, or bizarre behavior. So we need to ask those questions, because psychosis is usually associated with worse outcomes. History of substance abuse. Okay, so women with both the depression and bipolar disorder, they have higher rates of abuse of illicit drugs and alcohol in pregnancy, unfortunately. So we need to make sure that we are actively asking those questions and helping mothers, staying away from a substance as much as possible. Support, so it's our role as well to work on the family social support, because support is associated with better outcomes for our mothers. Make sure that we discuss access to treatment, so how easy or how difficult it is for that mother to come back to the clinic if some symptoms emerge. So we have to have a plan in place. We have here in Canada a service called Mother Risk. In the US and Europe, there are also services like that we can call, and we can ask information about the risk of particular medication in pregnancy or breastfeeding. So it's important for mothers to have that information. And patient desire, because one of the things about the research in this area is that I'm sure a lot of you have heard about the term randomized placebo-controlled trial. So this is sort of the gold standard way of doing research as far as treatment. So we blindly allocate people or randomize people to receive a treatment A or receive placebo. We cannot do that in pregnancy or postpartum. Like, it's unethical. It's not ethical to randomize moms and babies to treatment or no treatment. So the level of evidence, therefore, is lower than the other areas of medicine. And therefore, we really, really need to consider highly the patient's desire to do what she thinks is right for her and her baby, because the evidence is not very hard in terms of the treatment outcomes. So, in other words, education is the key of management of what we do with our patients every day. So another way of now talking about medication, which is I'm going to speak for the next 10 minutes or so about some of the medications. So when I explain to my patients and the residents and the medical students that rotate here with me, I tend to show them there are essentially three types of risks as far as the risk for the baby. So the first risk is women who conceive or get pregnant on a specific medication. So are there risk of birth defects with medication A or medication B? So that's one of the risks, getting pregnant on medication. So the second risk happens right immediately after the baby is born. So during pregnancy, the medication goes to the baby and back to the mother's liver to metabolize that medication. But once the baby is born, when the baby is born, there is some medication available floating in the baby's bloodstream. So it is then up to the baby's still immature liver to metabolize that medication that is in his or her bloodstream. So when that happens, that exposure to the medication can cause what is called poor neonatal adaptation syndrome. This is a syndrome that is well established, and we know the risks is 15 to 30% of babies. So 15 to 30% of babies exposed to medication, psychotropic medications, they may have the poor neonatal adaptation syndrome. In other words, 70 to 85% of babies exposed don't have this syndrome. So the Canadian Pediatric Society has a statement that is available online, and I'll be happy to give anyone that information later on, showing that this syndrome is typically mild and typically transient. And by transient, we mean hours, a couple of days, so the babies usually go home already feeling fine. But there are some cases that this syndrome can be more severe and cause babies difficulty feeding, difficulty breathing, respiratory assistance, and so on. And then there is the third type of risk, as I alluded in the beginning, which is the developmental issues. Does this medication impose a risk on my child moving forward for his or her developmental or milestone? So I'll touch upon some of these risks in the next slides. So as you can see, this is an ugly slide, and I apologize for that. We won't go over line by line, but this was published by the American College of Obstetrics and Gynecology Committee a while back, like 10 years now, with a list of the majority of the medications that we had available back then, and still the most medications that we have available today are here. And and then you have the letters of safety, A, B, C, D, and then X, and then the risks during lactation. So the FDA, the Food and Drug Administration in the US, is now moving away from this letter thing, because it's been found not to be very much useful. So FDA is now in the midst of changing the way that the risks of medications in pregnancy and breastfeeding are being reported. So stay tuned. This is something that is a work in progress. But as you can see, most medications are in the category C, which means that these medications can be used with caution. So risk cannot be ruled out, but we are allowed to prescribe those medications, majority of them in pregnancy. Now, in bipolar disorder specifically, just not too long ago, a few months ago, there's this paper that was published in one of the biggest medical journals, the New England Journal of Medicine, which is the largest study ever conducted as far as lithium and risk for malformation. So this is data from the US, more than 1 million pregnancies, so really large, nice, well done study. So they compared 1 million infants that were not exposed to lithium versus 663 infants that were exposed to either lithium or almost 2,000 infants that were exposed to another medication called lamotrigine. And they wanted to look at the risk of cardiac malformations in the first trimester. So what they found is that in babies that did not take lithium or lamotrigine, the risk of malformation, cardiac malformation, was 1.1%. Babies that use lamotrigine, the risk was not significantly different. Okay, so when this is the confidence interval here, when it crosses 1, means that there's not, they couldn't find a difference between being on lamotrigine or not, as far as the cardiac malformation, but lithium was associated with a risk for cardiac malformation. How much? 2.4%. So now mothers know that you know, they have a risk of 2.4% of malformations if they get pregnant using lithium. And then when they looked at the overall malformation, not just cardiac, but any type of malformation, they found that in babies that were not exposed to medications, the prevalence was 3.2%, which is average, which is normal, like the background of malformations. You know, we know it's around 4%, so this is about what we expect is the background risk for any malformation. Lamotrigine was not found significantly different than being non-exposed, so again, the difference is not significant. But lithium was. So the risk of overall malformation with lithium was 5.7%. So this is the difference of risk. So still, almost 95% of babies exposed to lithium in the first trimester will not have any malformation. So that's the risk that mothers should consider if they want or if they don't want to take lithium in pregnancy. What was interesting for us prescribers in terms of, they looked at the various doses that these women were using. So women who were using less than 600 milligrams a day or between 600 and 900, there was not a significant increase of malformation. Only in the group that was taking more than 900 milligrams a day, the risk was there. So this is also important for us to know that, you know, dosage of medication also matters. And in lamotrigine, the dosage didn't really matter much. Now there's another medication called Valproate or valproic acid. I think in the US it's called Depakote, if I'm not wrong. There is a high risk for neurotube defects with this medication. Very well established. It's about 2% of risk. So if you think about the neurotube, which is this, what you see here, closes at the end of the 4th week of pregnancy. So if someone conceives a baby in the middle of the menstrual cycle, 2 weeks later, he's supposed to have a menstrual cycle bleeding, and the bleeding doesn't come, and then they think that they might be pregnant. By the time that they discover that they are pregnant, it's already too late. So Valproate is a medication that will really, it's probably the worst medication to get pregnant on. It's safe to say that in terms of the medications that are most commonly used to treat bipolar disorder. So what is also important is that there is another study published in the New England Journal of Medicine showing that even if the baby is not born with any malformations, the exposure to Valproate in pregnancy is associated with lower IQ scores at 3 years of age. So there is evidence of neurodevelopmental issues in infants exposed to Valproate in pregnancy. So this is important to know, and we really contraindicate Valproate in the first trimester. Another large study showed that this medication was associated with all sorts of other malformations as well. So avoid Valproate. Carbamazepine or Tegretol is another medication that is commonly used in bipolar disorder. It has not been associated with risk for general malformation except this spina bifida. So spina bifida, the odds ratio is 2. The risk is 5 times lower than Valproate. So the bottom line is that try to avoid the use of carbamazepine in the first trimester. We also would not recommend. But if there's a patient that needs to choose between Valproate and carbamazepine has less risk than Valproate, if that's ever the case. So I already spoke about lamotrigine. Atypical antipsychotics. So one of the problems that we have in this area is that atypical antipsychotics are very, very commonly used in bipolar disorder. Like, people use a lot. But we don't have studies that is specifically looking at medication A or medication B. So the research thus far grouped them into this family of antipsychotics. So they studied women that took a bunch of different antipsychotics. So this is a problem. We need more individualized data. But probably this is one of the best studies ever published from Sweden, when they investigated the effects of maternal use of these medications in pregnancy, and the outcome was the risk for gestational diabetes and fetal growth. So they had a group of women that used olanzapine or clozapine, 100 and plus, a group of women that used any other antipsychotic, so 300 plus, and 300,000 women that didn't use any antipsychotic. So what they found is that the exposure to any antipsychotic was associated with risk for gestational diabetes. So this is something important to know, that these medications are associated with increased risk for this gestational diabetes. So, diet, exercise, moderate exercise compatible with gestation is something that can really help. They found that the risk for babies being small for gestational age was not significant once they adjust to confounders such as smoking, which has a huge, tobacco smoking has a huge impact on babies being born small. And they didn't find that the babies exposed to antipsychotics were large for gestational age either. What they found in the olanzapine clozapine group was more rates of microcephaly. So the heads were bigger, but they didn't discuss what the implications of that really were. And this is a study that is more recent from the National Pregnancy Registry of Atypical Antipsychotics in the US. So this registry is ongoing, and I would encourage everyone in the US to, send their data there. This is a study that looked at exposure to a whole bunch of antipsychotics. Here are aripiprazole, asenapine, clozapine, and so on, like a lot. And women were interviewed at baseline, and then at 7 months pregnancy, and then 3 months postpartum. And the main result is that they did not find high risk for major malformation with this atypical antipsychotic. So as far as malformation, it has not been proven that these medications can increase the risk. But see, the confidence interval here is really wide. So it is possible that in the future, once we have bigger samples, that we will identify some congenital malformation issues. So I would say at this point, this issue has not been solved because of small samples. Like 200 is not big enough for us to nail that. And I put a star here that this is a study that we were all waiting for in terms of what about the issue of the comparison between being on treatment in pregnancy and in pregnancy and not being on treatment. So this is the best study that I'm aware of, also from Sweden, published in the British Medical Journal a number of years back. So they investigated the risk of adverse pregnancy and birth outcomes in women who were treated versus women who were not treated for bipolar disorder. So this is something that we really needed to know. So they had 300 plus women who used lithium, valproate, carbamazepine, and antipsychotics, and they compared those women with 500 plus women with bipolar disorder not on treatment, and they had another group of moms with no bipolar disorder and no treatment, so 300,000 women. So the results were, women with bipolar disorder, regardless whether or not they were treated, the illness itself was associated with more tobacco smoking in pregnancy, more obesity, which is associated with worse obstetric outcomes, more use of alcohol and drugs in pregnancy, more C-section, more instrumental delivery like forceps or vacuum, and more preterm delivery. So all of these factors are associated with worse obstetric outcomes. So this was the rates of all of these factors were high in bipolar disorder, regardless of treatment. Now, women that were not receiving any treatment, they had more infants that were small for the gestational age, so smaller babies. They have more microcephaly, so smaller head size, and more neonatal hypoglycemia. So this happened in women that did not receive treatment more often. And in women that received treatment alone, they found a higher risk of congenital malformation. So in this cohort was 3.4% compared to 1.9% in women that were not on treatment and 2% in women that were not on treatment and didn't have bipolar disorder. So the prevalence of congenital malformations in Canada in 2004, which was the latest that I could get, was 4.8. So, the Swedes are doing really, really well in terms of the rates in the control populations, about 2%. So treatment was associated with high risk for malformations. What about breastfeeding? So a couple of years ago, Dr. Edward Vieta from Barcelona and his group published this really nice review on medications for bipolar disorder and breastfeeding. And this is the main result. So I don't have time to discuss the whole article here, so I'm just summarizing the results. But the article is here if anyone is interested. The preferred drug of choice in breastfeeding was either quetiapine or olanzapine. Carbamazepine and Valproate were options. I would say I would probably not recommend. My opinion is that I would not recommend a Valproate anyway in breastfeeding. Lamotrigine was an option, but maximum dosage of 200 milligrams a day. And why is that? Because the release of lamotrigine into the breast milk is sort of unpredictable. So for some women, the levels are higher, and for some women, the levels are lower. So we want to keep the dosage as low as possible in women on lamotrigine and breastfeeding. Lithium, it is an option, but with very, very careful monitoring of infant. I tend to suggest mothers not to breastfeed on lithium because lithium is also detected in the breast milk, and lithium can affect the thyroid and the kidneys, and the thyroid is obviously associated with our overall metabolism, and you don't want to slow down the metabolism of an infant. So that's my rationale why, but I have had many patients here in the clinic that they really wanted to breastfeed, and they really did not want to stop their lithium because they felt worse when they did that, and their infants did well. So, it is possible, but very, very careful monitoring of the infant. Risperidone is also an option, but data is relatively more limited than the other medications. So this is the summary. So the treatment decisions when, we have a patient in front of us and we are talking about what to do is never easy. So there's no easy answers because, like I said, we don't have like the nice randomized trials in the area of perinatal mental health. So what is our role? The role is to discuss the risks and benefits, tell our patients the magnitude of the risk, and discuss the limitations of the data, more or less what we discuss here today. Acknowledge what our patient thinks is right for her baby, and get the family members involved whenever possible. It's much better when the decision whether to continue medication or stop the medication comes not just from the mother, but also from the father of the baby and the support from the family and so on. Sleep is also something that we need to ask and we need to monitor. Sleep disturbances are very common in pregnancy. This is not data from bipolar disorder. This is data in terms of physiology of sleep in pregnancy and postpartum overall. So 2/3 of women have sleep problems, in pregnancy and in the postpartum period. So it's really, really very common. First trimester, nausea, vomiting, backaches, urinary frequency can disrupt sleep. Second trimester, the fetal movements, heartburn. Third trimester, again, the urinary frequency, and again, the backaches and the shortness of breath and the cramps and the itching. So a lot of things that are commonly seen in pregnancy can affect sleep. And sleep can decrease in pregnancy. It's been found increased night awakenings, decreased sleep efficiency, the REM sleep, which is more of the rapid eye movement sleep, which is the lighter sleep, is reduced. And then 3 weeks postpartum, it's both the light and the deep sleep are reduced. So it's really, really, really very common. So the course of sleep in pregnancy and postpartum is typically first postpartum week, the sleep is worse. And then 6 weeks, there's some sort of a normalization of the light sleep and the deep sleep, but the sleep efficiency is still low. And then it takes about 6 to 12 months for the full normalization of sleep in most mothers. Okay, each case is different, but this is the average. So our psychoeducation, when we discuss perinatal management with our patients, we tell them that bipolar disorder has been associated with obstetric and neonatal risks. So the illness itself has been associated with some risk. We saw some of the data, but the medications also have some risks, and some risks are different. So we need to discuss those risks with the mother to help her decide whether she wants or not to continue on the treatment. Certain risk factors are modifiable. So we can address sleep, we can address the issue of alcohol and drugs, decreased nicotine, psychosocial stress. So there are lots of things that we can do that can also help decrease the obstetric outcomes. But there are risks that we cannot modify, like the genetic risk, the family history. It's something that we are born with, we cannot modify. And there are differences between pregnancy and postpartum, so we always talk about that. I think this is my last slide. So this is a psychoeducational program. It's a systematic psychoeducational program that we developed with my colleague here, Dr. Cheryl Green, a psychologist, with Dr. Francesco Colon's support and supervision. He is from Barcelona, and other colleagues here. We haven't published this yet, but this is the systematic psychoeducational program we have here in our clinic. It's 8 weeks. So the first week, we talk about the understanding of bipolar disorder, the symptoms, the episodes, life charting. The second week, we talk about course and challenges of bipolar disorders in pregnancy, so the sleep issues. We introduce the sleep diary, sleep hygiene. And then we talk the third week, the course and challenges in postpartum. Remember the timing of the risk, the breastfeeding versus bottle feeding, role of the partners. So the partners take an active role, doing sometimes some of the night feeding so mothers can sleep. Risks and benefits of psychotropic medication. So we have one session just dedicated to the medication issues, and we invite the husbands or partners to attend. Fifth week is importance of treatment adherence. So what are the personal barriers? What is partial versus a full adherence? Ways to overcome it. And then the 6th week, we discuss early signs of relapse. So how can we detect relapse really early so we can be proactive instead of reactive? And then on the 7th week, we have a proactive planning in place. So what should I do if my manic or depressive symptoms come back? And we have this, what is called a fire extinguishing card, which has a name of a contact person and things that the mother needs to do if those symptoms come back. And then on the last week, we review the whole material again. So that was it for today. So to conclude, the women with bipolar disorder are more susceptible to relapse during the postpartum period, it's 37%, and to a less extent during pregnancy. Both psychotropic medications and the illness itself, they carry obstetric and neonatal risk, so we have to be educated about it. Education and shared care decision are key during the treatment planning. So with that, I would like to thank you all for your attention. This is my email. If anybody wants to follow up with me later on, I'll be happy to. It's 10 to 1, so I'm happy that we still have time for discussion. We have until 1 o'clock for discussion. So I hope you can send your questions to Debbie. And Debbie, please let me know if anybody has any question.
Yes, absolutely. Thank you, Dr. Frey, for that incredible information and insight research. I do have a couple of questions already, so I will share those with you. First would be, do you believe that postpartum bipolar disorder can be a totally separate mood disorder apart from postpartum psychosis, or are they linked together no matter what?
No, the research suggests that there is an overlap, but they're not necessarily the same thing. Because there is some literature, and I would again refer to Dr. Verly Berging's work. She has the most comprehensive work in postpartum psychosis, and there are certain differences between postpartum psychosis and postpartum bipolar disorder. So bipolar disorder can run with psychosis. So there is an overlap. But there are cases apparently in the literature where women had postpartum psychosis only, and they did not go on to develop full-blown long-term bipolar disorder. So I would say that with the evidence that we have, there is an overlap, and some suggest even a genetic overlap, but they are not necessarily. There are cases that run with postpartum psychosis and no long-term bipolar disorder course.
Excellent.
Very good question.
Thank you for that answer. The next question, is there a reason that some psychiatrists seem not to acknowledge the postpartum bipolar diagnosis if a patient did not show any signs of psychotic features?
So can you repeat the question again?
Would there be a reason that some psychiatrists don't acknowledge postpartum bipolar diagnosis when a patient doesn't show signs of psychotic features?
Okay, yeah, no, I mean, I fully agree with this, whoever asked the question. I mean, it's very unfortunate that perhaps the perinatal mental health education is not a core, sometimes educational role. I mean, there's not in the curriculum of psychiatry residency and in many universities. It's too bad that a lot of people, they graduate in psychiatry and they have very little education about perinatal mood disorders or perinatal mental health in general even. I think, you know, the universities at large can do better in terms of educating, you know, new specialists in terms of the importance of perinatal mental health. Of course, I'm fortunate to work here at McMaster, where we do have a clinic and a program of women's mental health, and I'm aware of many other universities that do very well, and they do have you know, good programs of perinatal mental health. But indeed, there are unfortunately you know, some programs where people, you know, they don't understand the link between bipolar disorder and then the postpartum period. Just so folks have an idea, I did not present this slide today, but there is a beautiful study also, I think from Denmark, it's definitely from Scandinavia, where they looked at psychiatric hospitalizations after delivery of the baby. And there is a spike in 2 weeks post-delivery. And when they follow this case to see what the diagnosis was, the majority were women with bipolar disorder. So there is a strong, and not necessarily they had a psychosis. So there is a strong link between postpartum episodes and bipolar disorder, irrespective of presence of psychotic symptoms. In fact, I would argue that most cases, most episodes of women with bipolar disorder postpartum do not run with psychotic symptoms. So if we are waiting to see psychosis to be able to correctly diagnose women, we're going to miss out the vast majority of cases, unfortunately. So I do agree with the person who asked this question. Very good question.
Wonderful, thank you. It looks like that's all the questions. We do have several comments and responses that are thanking you very much, as well as we thank you here at IBPF for sharing your time and expertise with us and our community. And we wish everyone a good day, and we'll see you at the next webinar. Thank you, Dr. Frey.
Thank you very much, Debbie, and the International Bipolar Foundation, and everyone online. It was a pleasure. Thank you.
Just X out and end the webinar.